Hello, we are Group 2 of 1NU4 and this is our case presentation on malaria.
Case study. Patient MO, 20-year-old female from Quezon City, has chief complaint of fever and chills.
Case history. 5 days prior to consultation, patient developed fever with temperature ranging from 38 to 40 degrees Celsius. Was temporarily relieved by taking 500 mg of paracetamol every 4 hours.
Personal and social history. Emma was an active medical mission volunteer that takes her to remote areas in the Mimaropa region of the Philippines. She went on a medical mission to Palawan 3 weeks prior to the onset of symptoms.
Diagnostic test for malaria. Laboratory examination. Slight anemia caused by the rupture of RBCs occurring at each erythrocytic stage of the life of the protozoa. Leukocyte count is low to normal but may be increased in very severe infections. Platelet count is decreased. Urinalysis is normal.
Diagnostic test for malaria. Thin and thick blood smear. Definitive diagnosis of malaria is made only with the identification of the parasite via the blood. By preparing a thick and thin blood smear, we are able to differentiate between the different species of malarial parasites.
Classification of Plasmodium, Plasmodium falciparum, Plasmodium vivax, Plasmodium ovale, and Plasmodium malaria.
Life cycle. The malaria parasite life cycle involves 2 hosts. During a blood meal, a malaria-infected female Anopheles mosquito inoculates sporozoite into the human host. Sporozoites infect liver cells and mature into schizons, which rupture and release merozoites. Of note, in Plasmodium vivax and Plasmodium ovale, a dormant stage, hypnozoites, can persist in the liver and cause relapses by invading the bloodstream weeks or even years later. After this initial replication in the liver, exoerythrocytic schizogony, the parasites undergo a sexual multiplication in the erythrocytes, erythrocytic schizogony. Merozoites infect red blood cells. The ring-stage trophozoites mature into schizons, which rupture releasing merozoites. Some parasites differentiate into sexual erythrocytic stages, gametocytes. Blood stage parasites are responsible for the clinical manifestations of the disease.
The microgametocytes and macrogametocytes are ingested by an Anopheles mosquito during a blood meal. The parasite's multiplication in the mosquito is known as the sporogonic cycle. While in the mosquito's stomach, the microgametes penetrate the macrogametes, generating zygotes. The zygotes in turn become motile and elongated, which invade the midgut wall of the mosquito where they develop into oocysts. The oocysts grow, rupture, and release sporozoites, which make their way by the mosquito's salivary glands. Inoculation of the sporozoites into a new human host perpetuates the malaria life cycle.
Mode of transmission. Anopheles mosquitoes bite only during the night and live in heavily forested areas. They need a water source that is mobile.
Epidemiology. Malaria is the 5th leading cause of death from infectious diseases worldwide. More than 500 million are infected, and the World Health Organization estimates that in 2008, malaria caused 190 to 311 million clinical episodes and 708,000 until 1,003,000 deaths. It is present in tropical areas and eradicated in North America, Europe, and Russia. 3.3 billion people, or half the world's population, live in areas at risk of malaria transmission in 109 countries and territories. It is considered endemic in the Philippines with unknown presence of resistant strains.
Prevention. Limit your outdoor activity between dusk and dawn, stay in screened or air-conditioned rooms, wear protective clothing, long pants, and long-sleeve shirts. Use insect repellent, use bed nets, use flying insect spray indoors and around sleeping areas. Avoid areas where malaria and mosquitoes are present if you are at risk.
Treatment. If you are going to a location where malaria is present, It is very important to take preventive medicines and to follow the correct schedule for taking them. The majority of people who become infected with malaria do not take preventive malaria medicines or do not follow the correct dosing schedule. The treatment for malaria are chloroquine and primaquine.
Pathophysiology, uncomplicated malaria, clinical manifestations, cold stage, feeling of coldness and exhibiting shivering, hot stage, becomes hot and flushed with headaches and vomiting, sweating stage, sweating returning to normal temperature and fatigue. Symptoms can be exhibited as a combination of multiple symptoms: fever, chills, sweats, headaches, nausea, vomiting, body aches, general malaise.
Pathophysiology. Physical findings are elevated temperatures, perspiration, weakness, enlarged spleen, mild jaundice, enlargement of the liver, increased respiratory rate, and in severe malaria includes the symptoms of uncomplicated malaria. This occurs when the infections are complicated by serious organ failure or abnormalities in the patient's blood or metabolism.
Pathophysiology, manifestations of severe malaria. Cerebral malaria, abnormal behavior, impairment of consciousness, seizures, coma, or other neurologic abnormalities. Severe anemia due to the hemolysis or destruction of the RBCs in the body. Hemoglobinuria or hemoglobin in the urine. Acute respiratory distress syndrome, which is an inflammation of the lungs which inhibits the oxygen exchange. Abnormality in blood coagulation. Low blood pressure due to cardiovascular collapse, acute renal failure, hyperparasitemia, which is more than 5% of the RBCs are infected by the malaria parasites, metabolic acidosis associated with hypoglycemia, which is excessive acidity of the blood and tissue fluid. These conditions need medical emergency immediately.
Case study, pathophysiology. Patient develops fever with temperature ranging from 38 to 40 degrees Celsius. Patient has not vomited or exhibited a cough or cold, nor has she had any changes in her bowel or bladder habits.
Case study. Diagnostic results. The laboratory examination is slightly abnormal. There is a slight anemia because of the rupture of the RBCs occurring at each erythrocytic stage of the life cycle of the protozoan and a slight thrombocytopenia. Thick and thin blood smear revealed that the patient was infected with the malarial Plasmodium species.
Case study, travel history. Patient regularly visits the Mimaropa region in the Philippines, especially in Palawan, and gets bitten by mosquitoes while there. Palawan, one of the places that researchers identified as having high malarial cases.
Appropriate treatment. The patient was given chloroquine. Parasite count, see through subsequent blood smears, progressively declined and was absent after 7 days.
Case study, prevention and management. Patients should have bed netting to prevent further spread of disease, applying anti-insect or mosquito repellent to prevent further bites. Avoid forested areas during the evening hours where Anopheles mosquitoes are known to be active.
This is Group 2 from 1 NUO4. Thank you for watching our case presentation on malaria.